Hello, my name is Stephanie Kirk, and today I will be presenting my research for my senior practicum in spring of 2020, Ohio Valley University, and my topic is dilated cardiomyopathy, more specifically directions for future diagnosis and treatment of the disease. So dilated cardiomyopathy is a common disease of the heart that typically results in enlargement of the left ventricle and decreased ventricular function. The prognosis is very poor. 50% of patients typically die within 5 years of their diagnosis, and about 10,000 Americans die of this disease every year. Current treatments are pretty limited. They focus on preventing symptom progression rather than treatment of underlying causes. However, new research does go beyond this to treat underlying causes of dilated cardiomyopathy. Implementation of patient and exposure history analysis, genetic testing, cardiac imaging, and myocardial biopsies and other diagnostic tools help this diagnosis go beyond general symptoms and allow each patient to receive a personalized diagnosis based on the underlying pathology of their case. Reformation of treatments options is also a goal, but this does fall behind that of diagnosis. Some treatments are being researched that target direct causes. Stem cell therapy and genetic manipulation are a couple examples, but these are still in pretty early stages of development. It'll be some time before they are available to patients. Cardiomyopathy is a general term for heart muscle dysfunction. It's defined as several diseases, including dilated cardiomyopathy, which I'm going to focus on today, hypertrophic cardiomyopathy, restricted cardiomyopathy, and arrhythmogenic right ventricular cardiomyopathy. Dilated cardiomyopathy, also called DCM, is the most common. It's characterized by enlargement and dysfunction of at least one of the ventricles, usually the left one, and impaired contraction of the left ventricle, which often results in restricted blood supply to body tissues. Diagnosis is based on this enlargement and impairment of the left ventricle. Physical examination and imaging, such as chest x-rays, electrocardiograms, echocardiograms, can help with diagnosis of DCM and differentiating between the different types of cardiomyopathies. So here's an example of what a normal heart would look like versus one with dilated cardiomyopathy. As you can see, the left ventricle is significantly larger in the DCM heart. This prevents proper blood pumping throughout the body, and you can see that again. This right here is an echocardiogram, and you can see versus the normal heart, the left ventricle is very small, where it's extremely large and dilated in the DCM patient. Dilated cardiomyopathy is a progressive disease. It tends to lead to heart failure with pretty low survival rates. Prognosis does improve if it's diagnosed and treated early, but it can be difficult because early cases in latent periods are typically asymptomatic, and symptoms will start arising once systolic function of the left ventricle is decreasing, which can cause breathing difficulties, leg swelling, fatigue, weakness, and essentially other symptoms of heart failure. And the prognosis of DCM typically is chronic heart failure for most patients, and the treatments are treated as such. They don't focus on underlying pathologies. They focus on preventing progression of heart failure. This typically includes lifestyle changes as the main treatments. This will be cessation of alcohol drinking and smoking, increased exercise and diet changes are some recommendations. Medications can also be used, such as beta blockers, to prevent the onset of future heart failure progression. And in severe cases, implanted devices such as cardioverter defibrillators can be placed into the heart to help it function better. Surgical reconstruction is an option, and in very severe cases, as a last resort, heart transplants are an option. So the purpose of my research was to review the current symptoms, workup, and diagnosis and treatment of dilated cardiomyopathy and compare them to outlooks for the future of clinical development and diagnosis and treatment. So as far as the diagnosis of cardiomyopathy, especially dilated cardiomyopathy, it typically has in the past been treated as a general disease. And while it does have a specific phenotype, it's not a disease in and of itself. It's more like a common phenotypic symptom of many diseases and many different causes, and it should be treated as different causes rather than as a general symptom. So increasing the diagnostic tools to explore dilated cardiomyopathy, there's changes in the workup of it, and changing in the classification of the disease. There's actually a new system of classifying DCM, which uses monofunctional state of the heart, involvement of other organs, genetic inheritance, etiology, and functional heart state in order to characterize each case individually rather than clumping them all as one. There are several different types based on this, and this uses family history and genetics, inflammatory causes such as myocarditis, which is essentially inflammation of the heart from pathological causes. And then it can also be caused by toxin, drug, and alcohol exposure. Certain drugs can cause inflammation of the heart, and extended alcohol exposure as well. And increasing the specificity of a diagnostic workup helps to individualize each person's diagnosis, which allows treatments to be targeted at each specific cause. So here's a chart that kind of shows the different diagnostics of it versus what they're looking for when they use these diagnostic tools. As you can see, I talked a little bit about an echo a minute ago, and I'm also going to really stress this endomyocardial biopsy. You can see electrocardiographs on there. That's we're all pretty familiar with those. Different kinds of imaging, and also genetic analysis is a big one. So these different workups can lead to different characterization, of each case of DCM. So myocarditis is an inflammation and immune response of the myocardium. It's typically caused by viruses, but it can be caused by bacteria, fungi, and other pathogens. The majority of patients who get myocarditis will recover without permanent damage, but as much as 20% will develop chronic DCM as a result. As I mentioned before in the chart above, endomyocardial biopsy can be helpful in diagnosis of specific histologies of each specific case. So a biopsy, especially for those patients who have had myocarditis, this helps to develop pathogen-specific treatment, so they get a biopsy of the cardiac tissue, and then they can use that those histological findings to direct treatment at a specific pathogen. Another limitation of DCM diagnosis is the lack of diagnostic criteria in early stages of the disease. Like I said before, it goes asymptomatic until the onset of heart failure in many cases. So they've been trying to find a phenotypic marker to diagnose it before the onset of symptoms. And here is kind of a chart that talks about the different periods of DCM. So here we have the latent period, which would be before the onset of any symptoms, and the goal of the latent period would essentially be prevention. So this is going to be through genetic testing and doing gene therapy and things of that nature. After that, there's the basically the onset period, and the goal of this period, of cases in this period, would be reversal of symptoms where possible, reversal of heart damage, and in addition, prevention of further progression of the disease. And then there is the advanced stage of DCM, This is going to be where your patient is in heart failure. Their main goal of this, it would be to prevent the onset of complete heart failure. Stem cell therapy are some options, but the main options through this period would be surgery, surgical reconstruction, implants, and potential organ transplants. All right, and this latent period, there was previously no way to know that this latent period of DCM was developing in the body, but a new type of imaging called myocardial deformation imaging actually tracks the strain of the heart, and this is an example of it over here. And it was found that those in latent period of DCM actually have decreased strain on the heart. So you can see in this chart here would be a normal heart, and you can see that's pretty steady, and you can see in this right here is the heart with latent period DCM, and you can see this significant decrease in stress on the heart. So that's a new way that they can see potential future cases of DCM before symptom onsets and before heart failure starts. All right, and dilated cardiomyopathy is also found to have a significant genetic component. Over 100 genes have been associated with DCM. Tissues and molecular mechanisms impacted by these genes can include the sarcomeres, Z-disc, sarcolemma, cytoskeleton, sarcoplasmic reticulum, cytoplasm, nuclear envelope, nucleus, ion channels, mitochondria, and extracellular matrix and lysosomes. So you can see many different aspects of cells and of tissues can be impacted by pathogenic genes that can cause DCM. Most of these have been found to follow an autosomal dominant inheritance pattern, as it can be seen here in this. It's an example of autosomal dominant inheritance of DCM. Individuals who are found to have a family history of DCM should receive genetic testing. This is to determine if they have any high-risk gene mutations that could cause DCM later in their life, and those with high risk should receive education about the risk for their condition, as well as a workup for DCM every 3 to 5 years. And the focus in their treatment at this point should really be in prevention of risk factors such as hypertension and things of those nature. All right, so I've talked a little bit about changes in the diagnosis of DCM that have occurred and that will continue to happen in the future. Now I'm going to talk a little bit about changes in treatment. Current treatments, as I said before, focus on symptom management and prevention of heart failure progression. But new potentials for treatment could focus on the underlying pathologies that cause DCM. Gene therapies are one option. And gene therapies can counteract pathologies of mutant genes. One possibility, involved correcting levels of proteins that are not adequately produced. Another is manipulation of RNA to reduce the pathology of the mutation. Genetic manipulation has great potential for DCM prevention therapy, but these methods have only been tested in animals right now, so further development will have to continue before they're available in humans. For those people in late-stage DCM, where they're essentially undergoing chronic heart failure, stem cell therapy is actually potentially an option for them to reverse the effects of the cardiac tissue damage. Many studies have displayed that stem cell therapy could be a very reliable source of heart failure treatment that improves cardiac function and decreases further disease progression. Although significant research still must be completed to determine which administration methods, there's several different ways of placing the stem cells into the heart, direct injection, and things of those nature, as well as several different types of stem cells that could be used, and these will need to be further tested before this is established as a treatment, but it does show great potential, especially for patients who are in late onset of DCM and heart failure. Okay, so current treatment, as I had mentioned, is very generalized. Since the disease can be asymptomatic until the onset of heart failure, treatment is often neglected with poor prognosis. Early diagnosis and treatment is the key to improving prognosis. Research has shifted to a more individualized standpoint with the use of etiological, genetic, and functional analysis to individualize the diagnosis of each patient. Implementation of family history and exposure history evaluation can help determine the primary and secondary causes of DCM. Further workup through biopsies, blood cultures, genetic testing, imaging such as echocardiograms, cardiac magnetic resonance imaging, and myocardial deformation imaging can be used to specify the pathology and prognosis and determine treatment directions for each patient. Many current treatments are directed at the phenotypic symptom of left ventricular enlargement in heart failure, but future directions of treatment should be aimed at the underlying cause of pathology that is causing DCM. And future directions for this for DCM research, recently they have been aimed at implementing new types of imaging and diagnostic tools that customize each diagnosis. But most treatments are not readily available to patients because they are either not fully developed or they, like genetic testing isn't available in every clinic. So that should be a focus when continuing to implement these new diagnostic tools. Some mechanism-specific treatments are being developed, but these are still undergoing research and trials. The completion of clinical trials is the biggest limiting factor in making these new treatments available to patients. In addition, some underlying causes of dilated cardiomyopathy don't have a viable treatment at all, such as toxin and electrical exposure. There's also DCM that's related to postpartum, and these really haven't been researched for any sort of treatment yet at all, so those need to be completed as well. Generally, the research for dilated cardiomyopathy is undergoing really big steps in the right direction. The biggest limiting factor is designing and completing clinical trials, so that needs to be the main focus for DCM in the future. However, there has been significant research going on recently. DCM is kind of a hot topic, I guess, right now. In the last 10 years, there have been significant research articles completed, lots of experiments, clinical trials, and just need to continue in the right direction, not only for diagnosis, but for treatment as well of DCM. All right, thank you for watching so much. This has been my Senior Practicum video. Thank you for watching.